Health authorities in South Africa are monitoring a significant development in Cape Town following reports that medical professionals have contracted hantavirus while providing care to patients. This marks a critical juncture for regional public health surveillance, as it involves the first documented instances of healthcare workers in the city becoming infected in a clinical environment. While hantaviruses are a global concern, the specific emergence of these cases in an urban medical centre in the Western Cape highlights the evolving challenges of zoonotic disease management. To understand the gravity of this report, one must look at the nature of the pathogen itself. Hantaviruses are a family of viruses spread mainly by rodents. Unlike many other viral threats that dominate news cycles, hantaviruses are not typically known for frequent person-to-person transmission. Instead, they are usually acquired through direct contact with the urine, feces, or saliva of infected rodents, or by breathing in contaminated air when those substances are disturbed. The fact that medical staff in Cape Town are now among the infected suggests a complex exposure scenario that warrants immediate investigation by epidemiological teams. This report focuses on the confirmed presence of the virus in a clinical setting, the biological mechanisms that allow the virus to jump from animal reservoirs to humans, and the specific implications for the city of Cape Town. For viewers unfamiliar with the virology, hantaviruses belong to the Bunyavirales order. In the Old World, which includes Europe, Asia, and Africa, these viruses often manifest as hemorrhagic fever with Renal syndrome, or HFRS. In the Americas, they more commonly cause hantavirus pulmonary syndrome. The reporting from Cape Town indicates a localized outbreak that has breached the barrier between the patient population and the frontline responders. This development is being treated with the highest level of caution because healthcare workers represent a vital pillar of the public health infrastructure. When those treating the sick become the patients themselves, it necessitates a rapid reassessment of hospital protocols, environmental controls, and personal protective equipment standards. The geography of this event is also significant. Cape Town is a major international hub with dense urban areas and a complex interface between human dwellings and local wildlife. While various strains of hantavirus have been identified across the African continent in the past, such as the Sangasu virus, the infection of medical personnel in an urban hospital setting represents a documented escalation in the intersection of clinical medicine and zoonotic pathology. This framing provides the necessary context for the unfolding situation. We are looking at a known pathogen appearing in a high-stakes environment, affecting those least expected to be vulnerable while under strict medical safeguards. The core of the investigation in Cape Town centres on the specific medical facilities where the infections occurred and the procedures that may have led to the exposure of the attending doctors. When a virus normally confined to rodent populations appears in a hospital, investigators look for two primary vectors: environmental contamination or a high viral load patient who may have acted as the source. In this instance, the focus is on the frontline medics who are providing direct care. In a typical hantavirus progression, the incubation period can range from 1 to several weeks, making it difficult to pinpoint the exact moment of transmission without rigorous contact tracing and genomic sequencing. In Cape Town, lab facilities are now tasked with identifying the specific strain involved. This process involves utilising polymerase reaction, or PCR, testing to detect the viral RNA and serological assays to look for antibodies. These diagnostic tools are essential because the early symptoms of hantavirus, fever, muscle aches, and fatigue, are often indistinguishable from more common illnesses like influenza or even malaria, which is a constant consideration in various parts of Africa. For the doctors in Cape Town, the infection represents an occupational hazard that underscores the unpredictable nature of zoonotic diseases. Officials are currently analysing whether the transmission occurred through the aerosolization of the virus during medical procedures. Certain interventions, such as intubation or the use of nebulizers, can create fine mists that, if the virus is present in the patient's secretions, could potentially be inhaled by staff. However, because hantavirus is traditionally not considered highly contagious between humans, the medical community is closely examining the environment of the clinic itself. Is it possible that the hospital structure had an undetected rodent presence, or was the viral load in the primary patient so high that standard precautions were bypassed? These are the questions facing the Western Cape Department of Health and National Biosecurity Agencies. The reports emphasise that while these doctors are being hailed for their dedication, the scientific priority is understanding the breakdown in infection control. If the virus is found to be a strain with a higher propensity for human-to-human transmission than previously documented, the global implications for travel and shipping would be substantial. At this stage, however, no such declarations have been made. The data remains focused on the Cape Town cluster. Hospitals in the region are reportedly tightening their biohazard protocols, ensuring that any patient presenting with unexplained febrile illness and a history of potential rodent exposure is handled with enhanced respiratory precautions. The contrast between the initial claims of infection and the verified clinical data will depend on the release of formal laboratory reports. Until then, the focus remains on the stabilisation of the infected personnel and the isolation of the original source of the pathogen within the Cape Town healthcare network. Prevention and public guidance remain the most effective tools in managing hantavirus risks, both for the medical community and the general population of Cape Town. Public health officials emphasise that while the infection of doctors is a serious matter, the risk to the average citizen can be significantly mitigated through environmental hygiene. The primary directive is the elimination of rodent habitats in and around homes and workplaces. This involves sealing even the smallest gaps in building foundations using metal flashing or cement, as mice and rats can squeeze through openings as small as a quarter inch. In the context of Cape Town's urban landscape, this means vigilant waste management and the securing of food supplies. For those tasked with cleaning areas where rodents may have been present, the guidance is specific. Never sweep or vacuum droppings, as this can kick up the very aerosols that carry the virus. Instead, the area should be thoroughly soaked with a disinfectant, such as a mixture of bleach and water, before being wiped down with paper towels. Within the clinical setting, the infection of these medics will likely lead to a permanent shift in how unexplained respiratory or renal distress is managed. Enhanced surveillance is now a priority, with labs across the country on high alert for similar cases. It is important to acknowledge the honest limits of our current knowledge regarding this specific Cape Town event. We do not yet know if this represents a new, more resilient strain of the virus, or if it was a singular lapse in protocol. Virology is a field of constant discovery, and what is true today may be refined as genomic data becomes available. There is no vaccine currently approved for hantavirus in many parts of the world, making supportive care the only treatment option for those who fall ill. This care usually involves managing fluid balance, providing oxygen therapy, and, in severe cases, using mechanical ventilation. The calm, evidence-based approach taken by South African health authorities aims to prevent panic while ensuring that the medical community is fully aware of the risks. As the investigation continues, the focus will remain on the health of the infected doctors and the safety of the patients they serve. The situation serves as a reminder that the boundary between human civilization and the natural world is porous, and our surveillance systems must be as adaptable as the pathogens they track. We will continue to monitor official statements and laboratory findings as they are released to the public. For more updates on global health reporting and emerging viral trends, consider subscribing to this channel. In Cape Town, the reported infection of medical personnel has triggered a rigorous response from the Western Cape Department of Health and the National Institute for Communicable Diseases, or NICD. When healthcare workers are identified as the primary victims of a zoonotic pathogen, the epidemiological investigation shifts immediately to identifying a potential breach in standard infection control measures or an unusual mode of transmission. In this case, the clinical setting becomes the centre of a complex laboratory inquiry. Officials are tasked with determining how these medics, despite presumably following standard protocols, became susceptible to the virus. In the context of hantavirus, this typically involves analysing the facility for rodent ingress or assessing the viral load of the patients being treated. While hantavirus is generally considered a non-contagious pathogen between humans, the medical community remains vigilant regarding rare instances of person-to-person spread, as seen historically with certain strains like the Andes virus. However, in the African context, the focus remains on the specific Old World strains that are known to cause hemorrhagic fever with Renal syndrome, or HFRS. The laboratory process for confirming these cases is exhaustive. Initial screenings utilize enzyme-linked immunosorbent assays, or ELISA, to detect the presence of specific antibodies, which indicates a recent or active infection, and IgG, which suggests a past exposure. Because the symptoms of hantavirus frequently mimic other regional threats such as Rift Valley fever, Crimean Congo hemorrhagic fever, or even severe presentations of leptospirosis, molecular testing is the gold standard for a definitive diagnosis. Polymerase chain reaction, or PCR, testing is being employed to detect viral RNA in the blood or tissue samples of the infected Cape Town doctors. This allows scientists to map the genetic sequence of the virus, providing clues as to whether the strain originated from local rodent populations, such as the African wood mouse, or if it represents a variant not previously documented in the region. This molecular surveillance is critical for public health agencies to determine if the threat is localized or if a broader environmental risk exists across the metropolitan area. Furthermore, the environmental aspect of the investigation cannot be overlooked. Surveillance teams are likely conducting rodent trapping and sampling in the vicinity of the medical facility to establish a link between the wildlife reservoir and the clinical cases. In South Africa, previous hantavirus research has identified various strains, yet the Sangasu virus remains a primary subject of study across the continent. If the Cape Town cases are linked to this or a related strain, it would mark a significant data point in the understanding of the virus's geographic reach and its ability to impact urban centres. The clinical progression being monitored in these healthcare workers typically involves a prodromal phase of high fever and severe back pain, followed by varying degrees of renal involvement or internal bleeding. Hospitals in the Western Cape are now operating under heightened biohazard awareness, ensuring that all medical staff utilise N95 or higher-rated respirators when handling patients with suspected zoonotic infections, as the primary route of transmission is the inhalation of aerosolized viral particles. The contrast between the initial reports of infected doctors and the technical reality of the lab results highlights the gap between public perception and the meticulous, slow-moving nature of virological verification. Until the NICD or the Department of Health releases the full genomic profile of the virus involved, the medical community remains in a state of high-alert surveillance, prioritizing the stabilization of the infected staff while securing the hospital environment against further contamination. In the wake of the infections in Cape Town, public health guidance has been elevated to address both the clinical risks and the broader community exposure potential. The primary defense against hantavirus remains the rigorous management of rodent populations and the environments they inhabit. Health officials stress that prevention is rooted in the seal-up, trap-up and clean-up strategy. For residents in urban and peri-urban areas of the Western Cape, this involves a meticulous inspection of dwellings to identify entry points. Because rodents can gain access through gaps as small as 6 mm, the use of durable materials like steel wool, hardware cloth, and cement is recommended for sealing holes around pipes, vents and foundations. Beyond physical barriers, the elimination of food sources and nesting sites is a critical pillar of long-term prevention. This includes securing trash in rodent-proof containers, keeping animal feed in sealed bins, and clearing thick vegetation or debris from the immediate perimeter of homes and medical facilities. These measures are not merely about pest control, they are essential biosecurity actions designed to reduce the density of the viral reservoir in close proximity to human activity, for individuals tasked with cleaning areas where rodents have been present. The technical procedure is specific and vital for preventing infection. The most dangerous mistake a person can make is to sweep or vacuum dry rodent droppings or nesting material. Such actions cause viral particles to become aerosolized, creating an invisible mist of contaminated dust that is easily inhaled. Instead, the established protocol requires the use of a disinfectant, most commonly a solution of 1 part bleach to 9 parts water. The affected area must be thoroughly soaked for at least 5 minutes before cleaning begins. This ensures that any active viral particles are neutralized and kept moist to prevent them from becoming airborne. When removing the material, the use of rubber or latex gloves is mandatory, and the waste must be sealed in double plastic bags for disposal. In high-risk settings or professional cleanups, the use of N95 respirators or higher-level protective gear is standard practice to provide a definitive barrier against inhalation. The broader surveillance strategy now being implemented follows the One Health approach, which recognizes that human health is inextricably linked to the health of animals and the shared environment. This involves continuous monitoring of rodent populations by zoologists and ecologists to track fluctuations in carrier density and viral prevalence. Within the hospital system, the Cape Town incident has prompted a reassessment of how frontline medics approach patients with high fever symptoms. Surveillance now includes a more detailed history-taking process, focusing on recent travel, housing conditions, and any potential contact with rodents. This allows for earlier isolation and the implementation of droplet and aerosol precautions before a formal diagnosis is even confirmed. Laboratory capacity is also being scaled to ensure that any suspected case can be processed with rapid turnaround PCR testing, reducing the window of uncertainty that puts staff at risk. However, significant limits to our knowledge remain. The scientific community is still investigating the exact circumstances of the Cape Town infections to determine if this specific strain possesses an atypical ability to spread in clinical settings. Until genomic sequencing is complete, it is unknown if this represents a mutation or if the exposure was the result of an exceptionally high viral load in a primary patient. There is also the ongoing challenge of the diagnostic gap, where hantavirus may go undetected because its symptoms overlap so heavily with other endemic diseases. The ethical priority for the Western Cape health authorities is to maintain transparency without inciting undue alarm. The focus is on protecting the medical workforce while ensuring the public understands that hantavirus, while serious, is not a disease of casual contact. The dedication shown by the infected doctors serves as a stark reminder of the risks inherent in modern medicine, where the front line of defense against zoonotic disease is often composed of individuals working in high-pressure environments. As we await further data from the National Institute for Communicable Diseases, the emphasis remains on vigilance, environmental hygiene, and the support of the medical community. For continued coverage of this and other developing public health stories, please consider subscribing.